Thank you for joining us for this insightful conversation with Commissioner Christina Curry of the Mayor's Office for People with Disability. I am Tiffany Keith, a program manager for the Office for Diversity and Inclusion. And today we will use this time to get to know Commissioner Curry better and explore barriers impacting people with disabilities. So just some housekeeping before we get started. This webinar will be recorded and shared following this session. We do have closed captioning available, as well as ASL interpreters available today. To access the closed captioning, click on the live transcript icon on the bottom of the toolbar, then click show subtitles, and you will be able to see the closed captioning. Last, we hope we have time, but we will be using the Q&A feature for any questions you may have. So don't be shy. Please use that feature. And again, if we have time, we will answer the questions towards the end of the webinar. So with that said, I'm going to introduce the amazing Commissioner Christina Curry. Commissioner Christina Curry was appointed to Commissioner of the Mayor's Office for People with Disabilities by Mayor Adams in August of 2022. She began her career in rehabilitation as an advocate for the minority, deaf, and hard of hearing communities at the Lexington Center for the Deaf. There, she expanded into the mental health field as a mental health counselor, working with the deaf and hard of hearing domestic violence victims and survivors through the Barrier-Free Living Domestic Violence Non-Residential Program. On weekends, Commissioner Curry will also work with the minority disabled community at the Community Counseling and Mediation at Brooklyn Outpatient Mental Health Facility. Commissioner Curry has a Bachelor of Arts degree in Psychology and Education from CUNY Hunter, whoop whoop, a Master's of Arts degree in Deafness Rehabilitation from New York University, a Master of Public Administration and in Emergency Management and Disaster Preparedness from Metropolitan College of New York. Locally, Commissioner Curry has participated in the Mayor's Office for People with Disabilities Disability Mentoring Day and has served on the Office of Emergency Management Special Needs Advisory Committee and the Disability Network of New York City. Originally from the Bronx, and I know we have some Bronx people in the audience, Commissioner Curry worked in Harlem for 20 plus years and considers it to be her second home. She served on the Community Board 10, on the Executive Personnel, Health and Human Services, LGBTQ Task Force, and on public safety committees. She also joined the Harlem Independent Living Center in 1999 as a program director before being promoted to executive director in 2001. While at Harlem Independent Living Center, Commissioner Curry provided disability deafness sensitivity training to the Manhattan District Attorney's Office, various hospitals within the New York Health and Hospital Corporation, and right here at Mount Sinai. So she is well-versed and she knows us. She also provided training at domestic violence agencies and shelters, local police precincts, community-based organizations, and schools. Statewide, she has served on the New York State HIV Advisory Board, the New York State HIV Planning and Prevention Board, and the New York State Independent Living Council Committee. Commissioner Curry was then appointed by former New York Governor David Paterson onto the executive board of the New York State Commission for the Blind and the Interagency Council for the Deaf, Hard of Hearing, and Deafblind. Nationally, okay, Commissioner Curry has served on some subcommittees attached to the National Council of Independent Living and the National Council on Disabilities. Additionally, she has worked with FEMA in Puerto Rico and with New York City Emergency Management on emergency preparedness in the disabled deaf communities. All I can say is wow, right? Wow. So without any further ado, I will turn it over to Commissioner Curry.
Thank you so much, Tiffany. And I'm looking forward to this. Thank you for everyone for patiently waiting. Yes, I have provided trainings for Mount Sinai for many years on disability, especially for the ER teams as it relates to domestic violence and the disabled communities and those who are deaf. So I've been working with Mount Sinai off and on since the other century, literally.
Wow, wow. And again,
Slightly older.
wow. And again, thank you. Thank you. And I'm grateful to be sitting here with you. You are a pillar of the community and have a wealth of knowledge that we believe will positively influence our faculty, staff, and students. So again, thank you. So I guess we can jump right on in, right? And I
Mhm.
told you that, we will structure this thing so we could touch everything and, make sure we touch all the topics. So our first topic is advocacy and personal motivation. So to start, what drove you to become an advocate for people with disabilities beyond your lived experience? And, we didn't touch on your lived experience. So if you want to just talk a little bit about that and then go into how you became an advocate, that would be great.
Okay, so let's start with my lived experience. Anyone in audiology that's listening in right now can tell I was not born deaf. I'm not prelingually deaf. I'm what's called postlingual. I lost my hearing as an adult. I've had an amazing speech teacher so that I could retain a level of speech that would assist me in working in the hearing world. I lost my sight in my left eye as an adult as well, but I was travel trained through an amazing agency, first starting with the New York State Commission for the Blind and just working my way through. And then I lost the ability to walk unassisted due to a cab accident. So I am disabled, but it took another disabled advocate to tell me, you're disabled, because I didn't see myself as such and did not self identify as such. But when, if asked, if pressed, I identify as deaf. Why? Because I prefer to communicate when possible using a sign language interpreter. What got me in the field, though, honestly, I worked on Wall Street. Things were happening that were not so good, and I decided it was time for a change. And I went to NYU to see if they had a program that I wanted, that I liked, that did not require me taking the GRE, MCAT, LSAT, or any other thing that I could get in from my master's. And deafness rehabilitation was it. And it made a little sense to me because I have a cousin who's deaf, but the family didn't sign. And I always saw how frustrated he was trying to communicate with the family. And I used to ask my mother, why are they screaming at him? That's not helping, because if it did, we'd all be on TV making money, just yelling to the ear, and now you hear. Come on. So I got into it, and excuse me, because of the timing, I was asked, did I want a scholarship? Who am I to say no? I'm like, yeah, it's the last one you got. I'll take it. And part of the requirement was learning sign language. And they said they would give a stipend for that. I'm all for learning a new language, and you're going to pay me to do it too. I'm really motivated now. And that's how I got in the field. But who really motivated me? My brother. My brother's younger than I am, but he's severely dyslexic. And I watched him grow up struggling to read, struggling to get by, and how my father did not understand, and how my mother would work with him, and how his friends would make fun of him. If you speak to my brother, you would know he's brilliant. He's a genius, but he has to keep it all up here because he can't read it and can't write it down. He also has trouble with numbers. They all are jumbled up as well. So my brother is the person that I look at as my biggest inspiration. And then my mom, who became blind as a result of domestic violence, or what we call now intimate partner violence. So watching my mom, who couldn't see but taught herself how to cook, again, with limited vision and all of that, the two of them are the people. Not they're great leaders in the field and everything, but my mother and my brother are my two go-to people on when I say I will get it done. It's because of them.
Thank you. I think that is amazing. And I think it's important, right? You had those role models right there in the family. So that is amazing. So what specific advice or lessons did they impart on you that really shaped your approach to this type of leadership and advocacy?
Well, thank you for that. My mom is a firm believer in you get to have one pity party. You get 10 minutes. After that, you either do something about it or just be quiet forever after. She doesn't want to hear it. And even after she lost her sight, she's not fully blind. She's what we call legally blind, the same as myself. I can't see in my left eye at all. She doesn't see in her right eye. And her whole philosophy was I'm not dead. So what's the problem? Let's just figure it out. My brother has always had the philosophy of as long as I'm on this side of the dirt, you can accomplish anything, you can get it done. It may take a while, it may feel difficult, but you can still do it because you're still breathing. And as long as you can still breathe, doesn't matter if you can't use your legs or arms or whatever, you can still accomplish something if you try. So I listen to that. So whenever I think this is too hard or I'm in too much pain, I look at the two of them and say, if they can do it, then I don't have an excuse. I have to get it done.
Thank you. I think that's advice that we all could live by, right? I think, we do, a lot of us could get into those challenging moments, and that advice right there will get us out. So I thank you for sharing that. But I do want to move on just to talk a little bit about some of the barriers and systemic change, right? And so, from the lens of the MOPD, what are some of the biggest barriers facing the disabled community today?
So many barriers. Pick one and we can go from there. But the first is stigma. People who are not disabled still tend to think that they can catch it from us. People are afraid to try to communicate with someone who's deaf or ASL dependent because when they say, oh, I don't do this, and my response is, I don't do that either. So let's come up with some other excuse, a better one. But it's the stigma, which is the hardest. And it's stigma for the person who's disabled and feeling the weight of judgment on you as a disabled person every time you leave your home. But the barriers, housing, education, medical, legal, pick a subject, and it's hard. It's still hard in 2024, but since this is Mount Sinai, let's focus on medicine and the barriers that exist for us, where the bias, where it's believed that we don't feel pain or we feel pain differently, or if you're in a wheelchair, you're a wheelchair user, and it's okay that you've never had a full body exam. How is that possible in 2024? But there are women that have never had a gynecological exam because they use a wheelchair, or they've never had a full exam because they use a chair. Or one doctor who, when they asked, how many children do you have? And I said, one. And I think it was a rhetorical question because he stopped typing or whatever and looked up. You have a kid? Yeah, I do. You want to talk to my husband? Like, why? Why that question? It's insulting. And every day we get insulted when we go to the doctor's office every single day. That's a barrier.
Mhm. So I'm glad you touched on that because I think there's so many things, so many ways we can go with that, right? And some of those brings up our big topic things like,
Mhm,
intersecting identities or combating stigma, which we will get to later. But with these
mhm.
barriers, how can we address them systemically, more specifically around the attitudinal barriers?
Ah, thank you for talking about attitudinal barriers. Attitudinal barriers are huge. It's if we come in, rather it's the clinic, the hospital, or private office, if your front desk has an attitude, we're already behind the eight ball. We're already thinking on I don't want to be here. We're already disengaged, disconnecting. You know, if you go to the front desk and the person, you're sitting in a chair and the person's sitting down and they don't even acknowledge that you're there. Or a lot of times when I go to the doctor's office, I don't hear my voice. So I prefer to sign until I get to know the people working there. But I can read some lips. It's not easy, by the way. Best lip reader gets about 50% of what's being said, the best. And if I go there and someone's like, ugh, deaf mute is here, or she's hearing impaired, I am not impaired. I can't hear, but there's nothing wrong with me that needs to be fixed. Go past the fact that I can't hear. But when you get someone who says, ah, she's wheelchair bound, how are we going to help her? Why did they bring the dog here? Can't you see where you're going? Comments like those tear into you. And every time you go to the doctor's office or the dentist's office, and this is what you're encountering, you don't want to go anymore. You're no longer interested. Or if you sit with the nurse who's taking your vitals and they pull your arm to take your blood pressure. Well, you've pulled it. I'm a New Yorker. You pull my arm, I'm going to react.
Mhm.
Let's not get that twisted. Just because we're disabled does not mean that we can't feel or we don't have feelings or the doctor is disengaged from us. He's not looking at us. He's not talking to us or she's not talking. Or my favorite is when you're asked, is there anybody with you? Well, when I get asked that question, I look to the right and look to the left and say, do you see anybody? I see me. Well, do you see anyone else? And if you do and I don't, one of us needs to be going to Bellevue. This is a problem. And I will make comments and sometimes the doctor will get it and sometimes they won't. But it's the fact that you don't see us as people, as individuals. You see us as disabilities. And that's
Mhm.
what you focus on. When I go to the doctor, I can't tell you how many times they focus on, you can't hear? No, my dude, I can't really. I haven't been able to hear since the 90s. You really can't see? No, really, I can't see. My left eye is useless at this point. Or they'll look at the cane. How long has that been? That's not why I'm here. I'm here about the fact that I'm having a heart problem. The fact that I can't hear or see is not connected to the heart. It's not connected to asthma. So
Mhm.
it goes back to stigma and it goes to the fact that we're not seen. We're not seen as people, as individuals.
Yeah, that was a lot, yeah. And it makes me think about those intersecting identities, right? Because we know the statistics around people with disabilities and having unmet healthcare needs. We know many people have intersecting identities based on sexual orientation, race, gender, religious beliefs, and the list can go on and on. So based on the data, and I just want to provide some context to the people that are joining, based on the data, CDC notes that 1 in 4 adults don't have a consistent healthcare provider or have an unmet healthcare need, and 1 in 6 people with disabilities do not have had a routine checkup in the past year. So, do you see intersecting identities playing a role in the numbers that I just presented?
Well, I can only use me, and I prefer to use me as an example. And I'll say yes. If your doctor's office has a physical barrier, there's one step in front in order to get in. If you're in a wheelchair, how do you get in?
Mhm.
I use a forearm crutch, but I can't bring my legs up to get up the stairs. So it's difficult. Why would I go there? Culturally, if you come from another country or your background is such that you only go to the doctor when your eye is hanging out and your arm is swinging and it's attached only by a vein, then you go. So if you got that and you have your family saying, ay, bendito, mira, it's okay, you don't have to go, then that also adds to it because your family doesn't want you to go because they're too afraid of what might or might not happen to you outside and you want to be independent. But can we just go back to the fact that when we get there, almost always we're asked, but who's with you?
Mhm.
Why do I need someone? I know what my needs are. I know what's wrong with me. Why are you waiting for mom and dad who are 80 something years old to come in and talk for me? I'm not a child. We're
Mhm.
adults, but yet we are treated as children. And many physicians will tell you, oh, I don't do that. I had a physician who I need an interpreter, and I had to wait 3 hours because he kept staring. He would poke his head in the room to see if I was still there. And the nurse manager came in and I said, I'm prepared for this. I have a sandwich, I got water, I got snacks. I will be here. You're paying for the interpreter, by the way. I will be here until I'm seen. They don't want to talk to us most of the time because
Mhm.
they feel that we don't know how to explain who we are or what we need, or because there's a language barrier on top of a communication barrier, or for a host of reasons. People are uncomfortable. As my brother explained to me, because he did work in the hospital in surgery, um, you're taught to repair, to fix, to make it get better. So when you see a disabled person, you can't do that. It's not part of your training. So you're uncomfortable with it. When I lost my sight in my left eye, that's my brother's specialty. And he looked at my chart and everything, and he said, yeah, I don't know what to do with you on that. So after that, he did not know what to do because he was taught, take out the eye, fix the eye. And here I am, and all of his peers would always say, oh, they were uncomfortable.
Mhm.
And my brother and his colleagues said, it's because you're not trained to see us as people. You see us as something you cannot fix. And it makes you uncomfortable because you weren't taught what to do, how to address it.
So it sounds like there, like you said earlier, there's just a lot of stigma. So if we
Mhm.
want to combat stigma and change those perceptions, as a leader in the field, what effective strategies can combat the stigma around disabilities?
Education,
Mhm.
outreach,
Mhm.
things like this, sensitivity training, but you have to pay attention. You have to go with an open mind. But it's training.
Mhm.
Education, education, education.
Mhm.
It should be in every medical school. You should have, at the very least, a class on disability. Just like there should be a class on how do you work with an older adult, i.e., senior citizens. There should be something in there so that you at least know you're going to encounter us.
Mhm.
We know we're disabled. Get over that. Get past your being uncomfortable and also acknowledge the fact you are uncomfortable around someone who you cannot fix. You can't change us. We just need you to deal with the chronic medical issue or maybe the degenerative issue of the disability. That's different. But acknowledge it, understand it, move past it. It's the same as saying, yeah, I'm Black. Okay, move past it. Get
Mhm.
on to the next thing. Don't focus on what you can't change. Focus on what you can change. Then we're good. I didn't pay you for my 15 minutes just to sit and talk about the fact that I can't hear, but my voice sounds so great. I still can't hear it. Can we get past that?
Mhm. Yes. So education is absolutely great, right? So that's where we
Mm-hmm.
start, but that doesn't necessarily always shift the perception, right? So how can we get to a place where we can shift public perception to focus on abilities and the contributions of people with disabilities? Because we know education is the tipping point. It's just the start, right? So how do we
Mm-hmm.
get past that and go beyond?
Okay, you're not gonna like this answer. The current crop that exists right now,
Mhm.
nothing we can do. And I say that in all sincerity. because you already have your preconceived notions about us. It's the generations coming up in med school, the ones who are in pre-med. It is education, it is outreach. It's also that generation that's willing to acknowledge, I've never worked with someone who's blind, deaf, blind. Can you teach me? That's it. I'm very serious about the older ones who say or talk a good game of, yes, we want to work with you, we want to know more, but it's always condescending.
Mhm.
It's the person who exaggerates when they are speaking because you're deaf, or because they feel that your IQ is lower because you are disabled. So they talk to you in a childlike way. That's most of the older physicians. Sorry, I put my brother in that group as well. I put my stepmom in there. I put my stepsister in that group. You haven't changed. You're
Mhm.
set in what you know, which is great. Medically, your profession, you know what you know. We're happy. You don't know what to do with us, and we make you uncomfortable. Moving on. I'll take the one that looks like they're 15 because they're learning to say, okay, I've never worked with someone like you. What do we do? So we
Mhm.
can say, get past the disability. Talk to me about why I'm here. The fact that I've never had a full body exam. Oh, why is that? Because the exam tables don't go up and down. So if you're a little person, if you're a person in a chair, if you're a person with brittle bone syndrome, etc., how do you get an exam if you can't get up on the table? No one's thought of that. It's the same for someone who's a senior. You need to have the table that goes up and down. What about for someone who wants a mammogram? They say that you should get it at a certain age. Well, you can't do it if it's not accessible for the disabled person. I don't need you to focus on my disability, but I need you to acknowledge the equipment that you're using right now is not accessible. So why would I go for an appointment if I can't get through the front door? Or if I can get to the front door, but the equipment's not accessible? Why? Why do it? Or the front desk has an attitude because they have to spend more time with me, or the doctor's ignoring me, or the nurse is literally trying to pull my arm out the socket. Why would we go? So our mortality rate is lower than the average non-disabled person because we're not there, we're not seen.
Mhm. So it sounds like we, as professionals in this field, we have to get comfortable being uncomfortable, and creating space like this. So I'm grateful for these type of conversation, and I think this is a great place to shift a little bit into the progress made and just the future in general. So in that, what is some progress you've witnessed in the disabled community over the years, and where do you feel there needs to be a more focused effort?
We've made strides in employment, transportation, and we're making strides in the medical or health community in so much that we are talking to the younger generations. We're trying to reach the older generation. And by the way, I'm in that group too. Um, but we're making strides in saying we will not accept negligence or being ignored or benign ignorance. We won't accept it anymore. Um, I'm older. I would really like to know, what do I need to do to get healthier? My I am overweight. I'm okay with that. But apparently nobody else is. Yet because I'm disabled, everyone has that defeatist attitude. Ah, you're overweight, but as long as you're not on my 600-pound life, you're okay. It's good. I don't want to get to that point.
Mhm.
So talk to me and see me. And where are we making progress is I can now say, stop, talk to me. Or you
Mhm.
know what? I don't have to come back here. I have options. I can go to another doctor. I can go to another location. And that's a stride that we are an achievement that we had not made before in the disability community because we were told to accept whatever was thrown at us, to accept the doctor talking over our head and looking for someone else or bringing a family member. Or for me, when I'm there with an interpreter that they're paying for, they tell the interpreter what's wrong with me, but not me. Now it's talk to me, look at me, see me, not the interpreter. Things like that. We're getting there. We're gaining our collective voice and saying no more. We need to be heard. We need to be seen.
I love that. I love that you said our collective voice, and it just leads right into my next question. I think you was reading my mind with this one. So, we could keep here, but today
Yeah, we here.
we're gonna stay on
Right here.
So how can we as healthcare providers empower people with disabilities to really advocate for themselves to, when they're in those situations, say, stop, view me as the whole person versus what you are, my disability. So how do we get there? How do we help people get to that place? Because I know it doesn't come overnight without support.
I love my favorite phrase of help me, help you, help me. And it kind of goes back to the question about cultural intersection and so forth. If you ask us a question, can you stop typing long enough to look at us, to let us answer, and let us know, especially someone who's deaf, we need to know that you're hearing us because we forget. You can put your head down, you can do all of this and still hear. For a deaf person, I don't remember that or I don't know that. So it's, can you just look at us for a moment when you ask the question and let us answer it? As hearing people, and all of you are hearing, you don't let us finish. None of you do. We start to answer and you start talking over us, and it's just, all right, whatever. And that goes for people in chairs. You don't look at us, you don't let us finish answering. Let us answer the question. Matter of fact, if we come out with questions for you, can you actually answer one or two of them? Can you, I guess it's also the syndrome of the what's called the white coat syndrome. Most people go into the doctor's office intimidated because you're wearing a white jacket and we're already afraid. Well, add to it if you're in a wheelchair, if you can't hear, can't see, things of that nature. It's acknowledge that we exist as people. That is the biggest step, no matter what. For all of your questions, acknowledge that we are people and not disabilities. If you're talking to someone in a wheelchair, how about you sit in your chair and look at that person eye to eye? Because if you're standing and the person's in a wheelchair and you're forcing that person to put their neck up to look at you, you're putting them in an inferior superior position. Doctor being superior, patient being inferior. If this person is having problems with their neck and now you're pushing that neck back, well, if they had laryngeal spasms or whatever, you're about to find out because you're putting them in an unnatural position for them to respond to you. Brittle bone syndrome. Again, if we can't get on the exam table, there's so much that you're missing on what could be done, should be done, etc. So, you know what? Best answer is I need the physicians, I need all of you to advocate and say, we need accessible equipment. We need accessible equipment because anyone can join my world at any time, at any place, any day. Doesn't matter your education or your income level, anytime. So therefore, advocate for it now because you don't know that you won't need it or a family member won't need it. Advocate for accessible equipment. That's what we need. That's the answer to everything. Should have said that from the very beginning. That's what I need.
That is the answer to everything. And I think it's the answer to my next question as well, because, I want to just give some guidance to emerging leaders as well. So you pretty much summed it up with medical equipment, accessible medical equipment. But in addition to that, what advice would you give to Mount Sinai employees just starting in disability equity work? And, I don't know if that's a real term, but I'm going to make it a term today.
Today it is, right? Okay.
Exactly.
So I'm going to throw it back to you. What does equity mean to you? What's equitable to me may not mean the same to you. I've always used the term that, having an ASL interpreter means I am now on the same level as a person who can hear. But that's not true. Take away my interpreter and it's unequal. There's no balance there. So what is equity? Equity is when I don't have to ask you, is your medical room accessible? Equity is I can just go in and get on that table because it lowers and I don't have to fight to get an exam. Equity is you already have access for me. I don't have to ask for the interpreter. I don't have to ask, hey, is this person actually, working here? They not assigned for real? Or is that your mother's son's cousin's daughter who learned 3 classes? Equity is the doctor and myself, the nurse and myself, we're on the same team. And it's team me to make me healthy. That's equity to me. I don't have to ask anymore. It's there. But for someone who's starting out, acknowledge what you don't know. When it comes, if you really need to focus on my disability, I'm the expert of me. I'm not the expert of the next person because I don't know their disability any more than you do. I'm the expert of me. So if I'm telling you that I don't want to take this medication because it makes the tinnitus go crazy, trust and believe I know what I'm talking about because I already went there. It's as an asthmatic, I'll tell you what medication works for me and what doesn't. So as a new person, listen to what I have to say. Help me help you help me so that I'm not in your office every 2 weeks, so that I'm not in the ER, so that I'm not in the clinic because no one's listening. Acknowledge what you don't know. Acknowledge if you're not comfortable with working with that particular disability and move forward. And that goes for the older group and the younger groups. It's just see us, see me for why I'm there, not because, oh yeah, my eye is bleeding right now, unless that's the reason I'm there.
Thank you. And again, I think these conversations are so important, right? And I think you sharing
Mhm,
those examples, because again, what does equity mean to people? I think that is so important with the work
mhm,
that everyone on this call does, really
mhm.
identify what equity means to you, see those gaps and kind of fill it. So thank you for sharing that. And again, having examples to tie it to really just makes you look at your area or your space or just how you're doing things day to day a little bit differently when you explore your own maybe unconscious bias, right? So I appreciate you
Yeah.
bringing that up. So we are running low on time, and I do want to just get to this last question because I think this
Mhm.
question is important. And we talk about it a lot in the Office for Diversity and Inclusion. It gets hard. It get hard to do this work. It gets hard, right? It is
Mhm.
heavy. Okay. So how can people sustain their efforts and remain hopeful amidst the challenges? Because we get hit with them every day.
So when I was a case manager and when I was a mental health therapist, I would tell the staff that worked for me, they're just visiting. You're in their world for 45 minutes. That's it. Okay, 45 minutes for us. I don't know for doctors right now. But so therefore, you got to detach at some point. You're only in their world visiting. So when a person comes up to you, a patient comes up, there's only but so much you can do. If you do what I ask, see us, listen to us, hear us, Okay, are you taking your meds? If I know that you're engaged with me, then that's going to assist me to become medically compliant, which means that my health is going to improve, hopefully. Then, okay, go home. Wait, before you go, have lunch if you can. Go to the bathroom, talk about other stuff. Don't obsess over me, over the disability. What did you do? What could you do? No, just acknowledge that we exist, acknowledge that our needs are slightly different, but don't get to the point where you're either so overwhelmed that you just don't want to deal with us, or you become so obsessed with us that you become the expert, because it's never going to happen. So just do what you're trained to. And by the way, if I haven't said it, I appreciate truly what physicians do and the nurses. By the way, love nurses. Love them because when I'm in the hospital, they're the ones who have to deal with me first. So nurses, yes, always. Doctors, love you because I'm still alive because of them. It's just, could you get past the disability? Trust me, I know I can't hear. I can't see. I've walked into enough walls to tell you I can't see. Get past it. But thank you for at least taking the time to try to learn a little bit more about us. That was it.
Thank you. Thank you. So we touched on pretty much everything. One area that we did not touch on, and I just want to touch on it briefly, is emergency preparedness, right? And I think it's important because this is your area. This is you.
Love it.
Emergency management during disasters. So one of the things we talked about is that it's not inclusive, right? It does not, when we're sending out messages, it may be missing some people. So can you just talk a little bit more about things that we can do in this industry, healthcare, to help with that?
Well, where to start on that one?
I don't know.
Um,
We only have a little bit of time.
That's like a whole nother conversation. When you're making your plans, when ER is making their plans on emergency evacuations or disaster preparedness, say there's a radiation meltdown or something, and you have to do the wash down, whatever. Did it ever occur to you that for some of us who are deafblind, how are you going to communicate to us? For those who are in chairs, especially motorized chairs, and we have to go through that shower, how does that work for someone who uses a chair? Because, you know, their whole system is in the arm, and if that gets wet, well, that 600-pound chair is not moving. What are we doing? For the person who's blind with a dog, are we washing the dog down too? Are we washing them separately? How do you tell the dog that? And how do you direct that person through the shower if they're blind? Because my understanding is you have to go in by yourself. Do you have anyone ready to assist and guide us through? How about getting the message out to your community that this is what you are prepared to do? If the ambulance service is not accessible for people who use wheelchairs, how are we getting them to the hospital anyway? Because you're not. So in the event of emergency, and we're putting the message out, this is where you go. Or nursing homes will discharge to hospitals. Okay, and what happens when the emergency's over? Where's that person going? You took the wheelchair. Where they going? How they getting home? How if the wheelchair is part of the independence of that person. You get rid of the chair, you get rid of their independence. There's so many things to talk about with emergency management and medicine and the disabled community that honestly, that's like another whole segment. Love to talk about it. The
Oh,
fact that when you're making plans, are you even thinking about us? Or
mm.
are we in that little column of people that aren't going to make it, along with the percentage of what you think senior citizens won't make? I personally don't feel like being put in that column. I want to live. Saw the movie, I want to live. So talk to us. There's a phrase in the disability community, nothing about us without us. If you're making plans for the community, could you at least talk to one person who's disabled? so you can get their perspective on does this work or not. But there's so much more we could talk about.
It sounds like it, and it sounds like you may have to come back for another session. You are
Oh,
always welcome. So we are just about at time. I do want to just ask, is there anything, again, we talked about so much, but is there one thing that you want everybody to walk away with or, to have today?
you intimidate us. When we walk into the or roll in or limp in to your office, you intimidate us. But we're New Yorkers, so we're going to come across as harsh and brash and everything else because we don't want you to know that you intimidate us and that we're a little bit scared. And we're sorry that we showed up late because Accessoride got lost. We're sorry that our legs didn't work and we had to cancel at the last minute and reschedule. We're sorry for the inconvenience, but you intimidate us. Could you at least give us the benefit of listening to us when we actually get there? Because we're as concerned about our health as everybody else is. And we don't want to have a shorter lifespan because we weren't seen. That's what I want, you know. Heck, can you just let us live?
That's a great place to end. And I just want to say thank you so, so much. We appreciate you joining us today for this amazing discussion. As I mentioned time and time throughout this conversation, these are the conversations we need to have, right?
Mm-hmm.
So again, I just want to say thank you. And I appreciate you all for joining us. We are at that 1 o'clock mark. So again, thank you
Thank
for
you.
joining us. And please remember to join the remainder of our Disability Awareness Month events. Thank you so much.
Thank you, everyone. And again, sorry couldn't get in earlier. Have a wonderful day. Thank you.
Thank you.